So we are first going to start off with heart disease and how common it is. And our first speaker is Dr. Chirala. She has a startup called InstaMed, which just focuses on remote patient monitoring. Anu is board certified in cardiovascular medicine, serves as a clinical assistant professor at Stanford University. So Anu, tell us something more about your InstaMed and how does it help track the patients with cardiac illness.
I first of all want to thank the TAL team to invite us and try to throw some light on remote patient monitoring and heart disease, which is a passion of mine. I am a practicing physician. I started in the South Bay in Morgan Hill for almost 28 years and have also joined the Stanford Cardiovascular team and have seen a lot of heart disease. And this journey towards remote patient monitoring actually started during the pandemic when we lost contact, the lights were switched off and we lost contact with the patients. And at that time, our wonderful Medicare, the CMS, came up with devices, remote patient monitoring. It was the most appropriate thing that the CMS ever did in the history of CMS, because during the pandemic it became very useful. Basically made it happen in my practice and for several other practices. So basically, I will explain briefly this. Remote patient monitoring is using electronic devices to connect patients to the doctor. And it was, like I said, during the pandemic when we lost the contact, it was very useful. We have 4 different kinds of devices that is supported for this specific remote patient monitoring. One is the blood pressure monitor, the pulse ox, the glucometer, and the weighing scale. All of these are usually used for patients with chronic illnesses, COPD or lung disease, and kidney disease and heart failure. Devices at home, they use them and the readings come automatically to the physician. The moment they take it at home, it's connected to the physician. And the physician has a team, a clinical services team that is monitoring this carefully in the background as per the orders of the physician and making sure that all patients are in perfect range of blood pressure. And if anybody goes out of range, the physician is notified and the medications are changed so the patient is back in range. So this is the program essentially, and the reason it was devised is very simple. Heart disease, as we all know, is the #1 killer everywhere, not only in US, especially in India. It's much worse, much more rampant, much more earlier. It's more malignant in India. So what are the pillars for this heart disease? Blood pressure, #1, easily treatable. Diabetes, malignant but can be treated. Cholesterol, smoking, obesity. So all of these are the underlying pillars that keep heart disease as #1 killer. So if we attack these chronic illnesses, then we are successful. We have tried for many years, but we were not successful. Now, with remote patient monitoring, it has been a success because we empower the patient. This is personalized medicine. Each patient gets their own device and the settings are set for that patient. The device is catered to the patient's chronic illness, whether it's diabetes or blood pressure or heart failure. The devices connect the patient to the doctor and with the help of a team to the practice and the doctor. And the doctor makes the appropriate changes. So every patient is walking with the doctor, going along with perfect numbers for whatever illness they have. And it's preventative. So you take care of these 4 major preventative aspects, you're a success in heart disease and of course heart failure. So this is the premise and it works. We now have 4 years experience and multiple thousands and thousands of patients have been enrolled, and it has been a very successful venture for our government and for the physicians who are using it and for the patients, because the patients are very much empowered. So this is the real life story of the physician who actually practices this day in and day out. And it is the dream. Of course, it can never happen without the IT support and the connected devices. So I just wanted to let you know that this is my experience that actually happens with these devices.
Thank you, Anu. So, how do you think this remote monitoring is going to help in India, where the prevalence of heart disease is even much more?
India very much needs this. And we really need, again, this is very new. It's a new baby in America. But as we go on, the gurus, the IT, the technology gurus, and AI have to figure out a way how it works in India. It is expensive. It is expensive in the US because each patient gets an electronic device and there's many people involved. So it's very expensive, but our government is very generous to our seniors and it pays for it. In India, we have to make it work. And I have been with some thought leaders trying to figure out how can we do this in India. We can do this if we share. Prices are expensive. In India, they can be made at a less cost. And in the remote villages, if these devices can be shared, then it can work because the cost is what it is. Plus, we have a lot of support with the primary health centers that can monitor this. And of course, now we have the remote monitoring. If we have virtual clinics and virtual assistants that are monitoring this, then we get these devices that is probably not one-to-one, but shared between several people, then we can make it work. That's how I believe it can work.
Thank you, Anu. So next is Dr. Anand. He is distinguished physician specializing in pediatrics and pain management and is a professor at the Stanford School of Medicine. He'll talk to us more about pediatric heart disease and how can it be managed with remote monitoring too, right?
I think one of the killers of children that is somewhat less known is congenital heart disease. In India, there are about 2.5 lakh, 250,000 children born with congenital heart disease every year. 90% of them don't survive to go to school. You know, a large percentage, about 60% don't even survive to their first birthday. Because congenital heart disease is hard to diagnose, once it is diagnosed, you know, it needs specialized treatment, which includes either a device closure or a surgical operation, more often the latter. But once that treatment is done, that child has a normal 60, 70, 80, whatever years of lifespan, you know, within that region, within that community. Unfortunately, there are only about 400 cardiac surgeons in India that specialize in congenital heart disease. It's not an easy, it's a long, long training pathway to get there. And then it's not lucrative. Why? Because these babies are being born to young parents who are very early in life, so they cannot afford it. So this is a huge killer of children. In fact, the current estimates from Niti Aayog are 30 to 40% of the infant mortality rate in India is because of congenital heart disease. And why is India it has twice the international incidence of congenital heart disease. Why is that happening? That's because of poor nutrition and some degree of pollution. A vast majority, 58% of mothers in India are anemic during pregnancy. That turns on certain homeobox genes that are unnecessarily activated, which cause some of these congenital malformations. Or it is some hidden hunger, so missing trace elements in their diet, or lack of protein, balanced first-class proteins in their diet, things like that. So, and then the other thing is the rapidly increasing pollution of water, air, soil, you name it, our environment. So I think although it's remarkable what the adult cardiology has done in terms of reducing death rates from myocardial infarction and stroke. But even in that area, there is space to do a lot more. And although remote monitoring tells you about your physiology, it doesn't tell you about your life. Life is more than what is physiology, you see. You can take care of cholesterol and, come off smoking and sort of have moderate exercise and all of the, eliminate smoking, eliminate all the risk factors, yet 50% of heart attacks are related to the quality of the person's thoughts and emotions. That is a huge factor. Happiness at work and happiness at home is a huge factor that explains the risk of heart disease. So, yes, there is a Pollyanna phase right now of AI being able to solve this problem, but I think maybe it may make it worse. Because when you focus on what you don't want a heart attack. When you focus on what you don't want, you focus on the problem. When you focus on what you want, then you focus on a solution. So what do I want? I want a healthy, happy, balanced life. And somehow these, constant concern about what is my heart rate now, what is my blood sugar now, it's making people into hypochondriacs. So I think we need to connect with ourselves rather than connect with our, physiology. And I think that's where a lot of the ancient wisdom of India will come into play. I also want to, mention, until about 10 years ago, congenital heart surgery was inaccessible to anyone who didn't have the 5 or 10 lakhs required to this. But there is now a network of hospitals, not only in India, 6 of them in India, but 3 of them outside India, which have no cash counter, no billing department. Cost completely free of cost. No charges of any kind. And these are the Sanjeevani hospitals that are located. Already 32,000 children have received, management of congenital heart disease. It's the world's largest program. Still under the radar as far as America and some of the developed world is concerned. So I just wanted to mention that if we put our hands together, then we can come together as a society and save these children, give them long, productive lives. Just that one intervention right around the time of birth.
Thank you, Dr. Anand. But you pointed out a big thing that prenatal care also needs to be focused on, right? So that's where prevention starts. That as soon as the conception occurs, then preventive care, prenatal care, proper prenatal care, and trickling down into the even remote places. Right?
Yeah. And even pre-reproductive period care. The girl child, I'll give you an example. My father had a twin sister. He was a double MA professor at Lahore University when partition happened. But his twin sister, who was far more intelligent than he is, far more, didn't study beyond the second grade. So this happens in every household. The nutrition, the resources of the family are taken away from the girl child because she's considered a liability. And so I think that's where, giving the prenatal care, but also giving the proper nutrition and education to children who are still young before their reproductive age, that's very important.
Thank you, Dr. Anand. So we move on to the next speaker, Sridhar Iyer, who actually will tell us how he is involved with training pediatric cardiothoracic surgeons and building a hospital in India which will cater to this particular problem.
Thank you. And thank you, the panel, TALHospitals, for having me here. And I think Dr. Anand introduced the problem as a perfect segue for me to continue on. So Why am I here? I'm not a board certified doctor. I'm not anywhere in the medical field. I'm an engineer. But either you can call it the second job or the first job nowadays is to work with the Saloni Heart Foundation. So I'm a board member in this nonprofit. And Saloni is my daughter's classmate who passed away in middle school. And her parents started this foundation in her memory. So getting back to the problem that we're talking about, as Dr. Anand introduced, about 250,000 children in India are born with congenital heart disease. They need medical intervention within the immediate few months to a year. Today, there are about 15,000 surgeries performed each year in India across all the hospitals. Only 2,000 of those surgeries are performed on children under the age of 5. So think about those numbers. 248,000 children in India born each year die a morbid death. And why? Early detection is not there. The primary clinics don't detect this fast enough. When the detection happens and they go to the doctor, the facilities are not there to perform these surgeries. And if the facilities are there, the doctors are not trained to do pediatric cardiac surgery. So you have tons and tons of cardiac surgeons in India, but pediatric cardiothoracic surgery is still relatively less amount of surgeons. And the main reason is they get an MCH and most of them come to the US and UK. The hospitals there, as Dr. Anand already mentioned, don't find it lucrative. So what we did with Saloni Heart Foundation is initially we said we'll provide second opinions based on the doctors that Saloni had consulted with. We have about 21 faculty members across the US who provide second opinions for free. So I urge you all to spread the word. If you know any family in India who has been diagnosed with CHD, reach out to Saloni Heart Foundation. Send all the papers, diagnostics, all of that stuff. And our panel of doctors who are heads of departments of Boston Children's, UCSF Children's Benioff, Washington, Philadelphia, all of those people are pro bono looking at your diagnostics and providing you second opinion. If this is the right diagnosis, is this the right recommendation for surgery and intervention? Are these the right hospitals? And if not, we come back to the Saloni Heart Foundation, where our volunteers will basically drive you towards the right hospital in India to get the intervention. Now that's not enough, right? Not even close. So we are at the run rate of about 1,000 second opinions per year. That's currently what we are doing right now. So think about it as like 3 inquiries come every night to us. And we are all completely volunteer driven here. So that's the rate at which we are responding right now. So if any of you want to volunteer and increase our capacity, please join us. But I think the biggest thing that we realized, and I think Dr. Anand talked about the commitment from the government of India and with the Niti Aayog, which is the new version of the Planning Commission of India. So Dr. V.K. Paul, who's the head of health in Niti Aayog, has worked with us. He's one of our advisors. And he connected us with the UP government because you can imagine the numbers. Majority of the children in North India don't have access. So we are now working with the UP government who have identified SGPGI Lucknow, which is like the third largest government teaching hospital in India, as our primary collaborator. So SGPGI Lucknow has now been committed where we are going to set up a 200-bed pediatric cardiac hospital who are dedicated to only training the faculty members. So we are collaborating with UCSF Children's Benioff. So I think, take a step back. If you remember the story of how the IITs were formed, like everybody here probably knows about IIT, whichever field you're in. IITs were formed with collaboration with MIT, Carnegie Mellon University, Caltech. We are basically trying to replicate that model. So SGPGI, which is the third largest teaching hospital in India, is going to be sponsored by UCSF Children's Benioff. So the head of pediatric cardiac of UCSF Children's Benioff goes in February, and now he's going to go in October with 15 of his faculty members to go train. In February, they went for 9 days. They performed surgeries from 7 in the morning till 10 in the night, non-stop. And they took on 9 patients, children who were declared terminal in India, and they all survived. And that is the process that we are trying to do now, where we are training the faculty members so they can train the next generation of surgeons who are trained in this field. And for that endeavor, I am the corporate fundraiser who's going out with my arms asking for people for money. So we are trying to raise about $60 million. We have about 36 beds right now in the adult cardiac surgery center, already dedicated as Saloni Heart Center. And so we are raising about $2 million right now. Just look in your pockets. That money is required to, and this is the complication. We have an OR, we have 36 beds, but it's not enough for those beds to become pediatric cardiac surgery beds, because they need different sets of equipment, they need different sets of surgical instruments, and that's about $2 million for 36 beds to be converted. So that's the cost investment, the capex investment. On the other side, the government of India and the UP government has been extremely generous. They recognize this problem. They want to do something about it, and they are hiring already. They have opened a rec for 45 faculty members. They have already opened a rec for 2,500 nurses. 350 nurses have already been hired. We have training the nurses in all the different hospitals nearby and getting them ready here. So I think the idea is, with Saloni Art Center, we are hoping to be a multiplicative effect, and we can take these 15,000 surgeries per year to close to 50,000 surgeries a year to start with. And then once we have Saloni Art Center in SGPGI Lucknow, hopefully we will get Boston Children's Hospital to sponsor AIMS XYZ. And the Niti Aayog wants us to set up a Saloni Art Center in 20 AIMS by the end of this decade. So that's the journey that we are on, and hopefully some or all of you will join us in this journey. Thank you.
Yeah, that's wonderful. You know, I hope this is just the first step, and every state has it, right? And you can build it like the root system, that from the primary healthcare center in a remote village, they can reach Lucknow,
Yes.
right? The problem has to be spotted first, and for it to go through a channel and reach the place where it has to.
Exactly. And I think the first thing when the government of India asked us is, why are you a non-profit based in the US interested in this? Well, we have a personal story, Saloni. Second is, they said, why don't you go to the private hospitals? And the point is, private hospitals are looking at ROI. So we'll probably use all our resources, train 2 doctors, and they'll perform some surgeries, but they will only perform surgeries that are having a high chance of success. So, as for example, Dr. Anand pointed out, the Sanjeevani set of hospitals, they are focused on saving as many children as possible. So in that process, if there is a child who has to deal with a complex CHD, how do you prioritize that? And the idea is, they will probably refer them to Saloni Heart Center. That's how we are collaborating with every hospital that you can think of. We are in touch with every hospital in India, be it the Satya Sai hospitals, the Mata Amritmai hospitals. We are collaborating with all of them, because this is not a competition, right? We are all trying to save children's life, and we all have to collaborate with each other. And we are hoping that Saloni Art Center will be the place where all the complex terminal children are sent, and we try to save them. That's the point.
That's wonderful. Yeah, so we'll be open to questions after our last speaker. Sreevani Singaraju is an experienced director of pharmacy and a chief medical officer for COVID vaccine clinics. With 10 plus years of pharmacy management, she's also the founder and CEO of Qubit Wellness Pharmacy, which focuses on preventative care and has received 300 positive Google reviews. So over to you, Sreevani.
Thank you so much. I do want to start with a gratitude to everyone. I'm grateful to be here with all these stalwarts in healthcare and technology. As Ratan Tata just said, I've been following him, and the biggest innovation of the century is integration of biology and technology, and that will always be great. And my journey started, I think I've been in pharmacology, pharmacokinetics for a long time. My mother is a known COPD patient. Since the time I've known her, I've seen her going through a lot of asthmatic attacks. She was using only, rescue inhalers. Back then, there was no protocol, right? Like maintenance meds or, follow-up, regular physical, care. Then she ends up with the diabetes from the rescue inhalers and overuse of steroids, and that turned into congestive heart failure. So I've been in this journey even before I joined my medical college and pharmacological college. And then my great uncle, he's very involved in my studies. He would allow me to study everything written in the pharmacology book. He would not let me flip the page. He's like, everything is important. Read every line, every molecule matters. So that's why I named my pharmacy as Qubit. As you all know in IT term, Qubit means quantum particles, very important in defining and shaping the quantum world. So I believe in preventative care at quantum level. Everyone should pay attention to each and everything that goes into your body. And at Qubit Wellness, I'm very proud to say I have 300 Google reviews. I have 200 patients in my realm. Not everyone has come to the pharmacy, but they know me and I know them by name, their family, their cultural sensitivities, what they need. And I advocate their need to the physicians and advocate physicians' diagnosis to my patients. Sometimes my patients come and tell me, oh, this doctor has overdiagnosed me. I don't want to take this medication. I'm like, no, looking at your clinical notes, I can tell why is this. You invest now, the next 5 years will be good for you. Just like your retirement plan. Invest now in your healthcare, you'll have a better future at retirement. Don't start at treatment, start at preventative. So my goal is to educate, advocate doctors to patients, patients to doctors. And in US, our biggest hurdle is insurance. Sometimes we have to cross that path. So I try my best to advocate that path to insurance and clear the hurdle. And this morning I was in CDC meeting, CAPHA meeting about updating my vaccines. And Ashish Jha, our physician for CDC, is a COVID-19 management physician. He wants to make flu vaccine over the counter, as easy as possible to pick up a grocery item. Who wants to wait in line, waste their time instead of binge watching at home, right? I felt it is very innovative, very exciting to have a flu vaccine over the shelf. And don't worry, these are not injectables you want to inject yourself into your butt or arm. This is only nasal spray. So I said, okay, fine, it's cute and innovative. I am there to integrate any innovative idea, exciting idea that comes in the Silicon Valley. I can't escape innovation into IT. So in my pharmacy, we have telemedicine, tele-virtual consultations, where my patients don't have time during weekday to pick up when they want pick up or when they want delivered. So I set up after hours at their convenience time and do consultations, help them understand why this was prescribed, how should be taken. So I help a lot with compliance. In my pharmacy, you will not see any prescription sitting there for 10 days. The prescriber prescribes, I consult them, and it is there at their door. And we happily help them understand and continue the care.
Yeah. How about devising a small preventive cardiology kit of nitroglycerine and aspirin? And
I am actually working with an Apple intern. I'm trying to figure out, especially the inhalers. People do not understand how important those inhalers are. If your asthma is not controlled, how it will impact the cardiac health. So I'm actually working with an intern who can put a sensor in inhaler. When it goes down, it triggers the patient. It's time to refill, not just the numbers.
One of the things that has changed over the last few years is ordering the CT calcium score, right? So I would like Anu to talk about it a little bit and explain how that has helped. And sometimes I've had patients who refuse to take the statin. They say that, no, the statin increases my blood sugar, the statin gives me muscle aches. I have read this, they highlight everything that is in the PI and bring it back to me. And so I tell them that, okay, go and do the CT calcium score. So Anu will talk a little more about how that has helped.
The morbidity and mortality for heart disease is not only great in the whole world, but is greater in India. And every day we hear about young people dying in India. Young, it attacks the young, 30s, 40s. And we have South Asian Heart Center here in El Camino that's doing a phenomenal job in trying to promote awareness and prevention. And the youngest people we have seen here is in the 20s, and all Indians. They get it very severe at a young age. But I first want everybody to understand that heart disease is preventable. Before it's treatable, it's preventable. It's really preventable, and these 4 pillars, the mass education is very much needed. It's there here. We have our annual wellness checkups. We have our primary cares who take care of us. In India, that is lacking. We need a lot more awareness. And I have had these discussions, but it has to start maybe at the level of the government opening these centers where people are screened. And screening can start very simply with just blood pressures. That's what if we have these remote monitoring devices that are kept in many of the rural areas and people are screened, blood pressure, diabetes, cholesterol, very easy to screen. And then a certain percentage will fall out, like 30%, 30 to 40%. In Tamil Nadu, 40 to 50% are pre-diabetics. Some states, Punjab, Tamil Nadu, Andhra Pradesh have a lot more diabetes. So once they get screened, they fall out, then you do the second level of screening for these patients. More advanced testing. And doing something as simple as a coronary artery calcium scoring. Very simple test. You need a CT scan, but you don't need a fancy CT scan like an angiogram. It's a very simple CT scan that can be placed in many areas in India where they get a 5-minute scan and they'll give you your score of plaque inside your heart in the coronary arteries. Very big indicator, very powerful indicator, prognostic indicator. It really will help weed out all these high-risk patients, because once these patients know they have something, they listen to you. They will change their lifestyle. Just saying, do it, they won't. But once they know that they have a lot of blockage in their heart, they can have the appropriate testing and the treatment, and they will be empowered with you to take care of them. My plea is, again, at the grassroots levels, to try to take care of the chronic illnesses, screen the population for the chronic illnesses, and then do higher level of testing, including coronary CT angiogram, and even there's a blood test called lipoprotein A, which 30% of the population in India has it. Very common, and that's one of the risk factors why they get it so early. And that is seen when you're born, so it's genetic. So testing some of these high-risk patients early on, there is treatment for everything that I'm talking about. Treatment that's curable. So heart disease is treatable, is preventable, curable, and my plea is using technology with remote patient monitoring will take us, far ahead in this game to prevent heart disease.
I have a very good friend, know them for decades. So he had heart attack when he was very young, 40. He was in a Google office meeting. He sensed some kind of tightness, and he was searching on the Google, what are the signs of heartburn? And then it got worse, and he's like, okay, I'll close the meeting. And he went into the parking lot. He started searching, what are the signs of heart attack? He didn't imagine. But then he was like passing out, and then he called 911. They took him to Stanford Hospital. He got 3 arteries blocked, stents. And having a pharmacist friend is difficult for him, because in every party he has to hide behind me to eat his gulab jamun. So now he's 53, and he saw me wearing CGM. I have a concierge physician. I have a familial history of atherosclerosis. My physician suggested, and I love all the latest technology. There are some patients who don't like to be attached to any gadgets, right? They're like, Sreevani, I don't want gadget. I don't like anything hooked to me. But I'm like, don't wait until you get a catheter in your bladder. Start with the preventative care. So this person, my friend, really, really interested, saw me wearing, it helped me a lot to understand as a pharmacologist with, quantum care and all. And he went to his cardiologist. He had a meeting appointment after 6 months, and he expressed his concern. My pharmacist friend is pushing me to get a CGM and maybe some weight loss medication I was recommending. But the cardiologist said, I can't prescribe you CGM. It's not my mete. You have to ask from your PCP. The next PCP appointment is 6 months. So why is that? It's preventative, in my opinion.
Very, very important. Let's talk about diabetes and all of us here, and especially in India, pre-diabetes. Diabetes, when you have diabetes in US or in medical literature, you're called CAD equivalent. If you have diabetes, you have heart disease, period. That's it. You have diabetes, you have heart disease. So diabetic patient is treated as already you have heart disease. So CGM is nothing but a continuous glucose monitoring, which the Libra was the first one that came out, and it's prescribed by a physician. So like blood pressure, even diabetes early on can be treated, and tremendous benefit can be there by catching it early and treating it early. Now, everybody does not have access to CGM. But recently, just as a few months ago, Dexcom came up with Stelo. I think I already told Anuradha about this. And I'm not a diabetic or a pre-diabetic, but I wanted to try it so I could talk to my patients, and I'm wearing one now. And I urge everyone, and this should also happen in India. We have to make it happen in India. It brings about tremendous awareness. It's a small, you buy it over the counter, you go to Dexcom.com and you order it just one time. Spend your $100 for 1 month. You get a CGM, you and your husband share it. And all you do is, it'll give you continuous glucose monitoring for 1 month or 15 days. And every time you eat, it'll tell you what your sugar is. And in that 15 days or 1 month, you will learn these things are not good for me. These things are not good for me, and you will, because it'll show you a nice spike, it'll beep, it'll tell you, and then you will try your best to change because you want to be healthy. And if you know your spikes are too high, you're already diabetic and you go to your doctor. So that this is all new. So it's called Stelo. You don't need a doctor's prescription. Otherwise, unless you're a diabetic, you will not get continuous glucose monitoring. It's not going to be paid for the insurance. But the Stelo is, and it's not much. I mean, for us in US, in India, it's going to be expensive. Nobody's going to spend $100. But I'm sure India, they can figure out how to make a less expensive Stelo that they can start using, and people will notice that unfortunately, most of the things that we eat in India will really, really raise our blood sugars. So there has to be first awareness, then there can be a change. You can't have a change without awareness. So first we have to keep the awareness, and I'm glad you brought it up because you can do it now with Stelo. Try it out. There's no harm in putting this on. It's painless. Put it on for a few weeks, see what you're eating, see what your spikes are, and say, I'm going to try to avoid these. I'm going to try to avoid that. And then tell other friends, because a lot of people can benefit. And as a whole, as a community, we'll benefit when we save lives by treating diabetes and catching it early. Thank you. That was great.
Yeah, thank you. So that concludes our heart disease and the prevention and management session, and hope you all gained from this. Thank you, TALHospitals, for inviting us.